This film is intended for eye surgeons for training and education purposes. Before learning the techniques of CTR insertion, let's understand what are the intraoperative clues that tell us that we may be dealing with an eye with weak zonules. Many times it does happen that we actually realize during surgery that the zonules are weak. There are certain subtle signs which we need to pick up. As I'm puncturing the anterior capsule, I can see the folds and wrinkling of the capsule. This is a classical sign suggesting that zonules could be weak. In this case of an hypermature cataract, tearing the capsule is difficult and I can see there is wrinkling of the capsule. Another case of generalized zonular weakness. The wrinkling of the adjacent capsule is clearly visible when the rhexis is being performed. All these subtle signs warrant us regarding the health of the zonules. Many times we realize that after hydrodissection, the nucleus rotation is difficult. In these clips, it is evident that the bag tends to be stressed during nucleus rotation. Another sign is when we notice that the rhexis margin loses circularity. It appears D-shaped. All of these situations warrant the insertion of a CTR. There are different techniques described in literature for introducing the CTR, each with its own potential pros and cons. We need to choose a technique which suits us the best. The ultimate goal, however, is to ensure that the process of CTR insertion should be as traumatic as possible for the zonules. I prefer the manual technique. I just use a pair of McPherson's forceps with 2 Sinskey hooks to implant the CTR. Let me demonstrate my standard technique for CTR insertion. This is a case of a localized zonular dehiscence. After rhexis has been performed, cortical cleaving hydrodissection is done, which is so critical in these eyes. After hydrodissection, I am injecting cohesive OVD, sodium hyaluronate, under the capsule. This viscodissection helps to create space between the capsule and the cortex. And then the CTR is manipulated through the side port using forceps bimanually. The CTR is gently introduced into the subcapsular space which has been created. Once in the space, the ring is pushed progressively in a plane parallel to that of the capsular bag. The ring is now seen traversing across the region of the zonular dehiscence. A Sinskey hook is introduced through the non-dominant hand, and this supports the ring while the ring is being dialed gently into the bag. The bimanual technique helps me to control the process of CTR insertion pretty well. Moving on to the next case. After rhexis, I am performing hydrodissection, and at this stage I realize that the nucleus is not free from its attachment to the bag, and the bag moves when the nucleus is being moved. At this stage I decide to insert the ring. I am injecting OVD under the capsule. This will create some space. The CTR is then gently threaded under the rhexis margin. Care is to be taken that the terminal edge of the ring is not vertical but lies flat and parallel to the anterior capsule. This ensures that the ring will not distort the bag during insertion. Again, the Sinskey hook in my left hand compresses on the ring to ensure that the stress is minimized. It comes in handy to compress and gently guide the remaining portion of the ring under the rhexis. A standardized protocol which I usually use is as follows. First, it is going to be cortical cleaving hydrodissection. Then aspirate a little bit of a cortex if needed, depending upon the type of cataract which you're having. Use cohesive OVD to create space and flatten out the cortex away from the capsule. This aids in easier insertion of the ring and minimizes the chances of cortex entrapment. The ring is held by two McPherson forceps and introduced into the eye through the side port and gently slid under the rhexis margin. The CTR is then wheeled into the bag, and once more than 1/3 of the ring is introduced into the eye, the second instrument is introduced. The second instrument, usually a Sinskey hook, is used to compress the ring during insertion. This will minimize the stress induced on the zonules. The final part of the ring is then guided under the rhexis by using another Sinskey hook, and the second instrument helps to release the ring if the hook gets stuck. Putting the ring before the nucleus removal can be intimidating, especially for the beginner surgeon. But few practical tips which are very critical, we need to understand them. One of them is to perform the cortical cleaving hydrodissection. Cortical cleaving hydrodissection before putting in the ring ensures easy insertion of the ring, minimizes the chances of the cortex being entrapped by the ring, and finally easy removal of the cortex even if the cortex gets entrapped in the ring. A slight modification of cortex removal technique will also aid in easy removal of the cortex. Instead of the traditional technique of stripping the cortex in a radial motion, we can use a tangential motion which helps in negotiating the entrapped cortex better. The tangential stripping of the cortex is also very beneficial in cortex removal in all eyes with zonular weakness. Now moving on to the next case, this is a traumatic subluxated cataract with 3 to 4 clock hours of zonular dehiscence. And after the rhexis is done, I have placed a capsular hook to support the area of zonular dehiscence. After creating some space under the anterior capsule, I am using the CTR. I'm trying to negotiate it and gently manipulate it. The point to note here is the direction in which the CTR is being threaded and its orientation with respect to the zonular dehiscence. This is very critical for us to understand because we want to support the area of the zonular dehiscence first before moving the ring around and supporting the other quadrants. So once the ring is placed, again we are emulsifying the nucleus and the case is done. An important concept we need to understand regarding the site of insertion and orientation of the ring when being used in such eyes with localized zonular dehiscence. The thumb rule is to ensure that the ring when introduced should support the area of zonular dehiscence first, followed by supporting the healthier areas of the capsular bag. In this case, the CTR is introduced and supports the area of zonular dehiscence and then is gently maneuvered so that the remaining part of the capsular bag is supported well enough. On the contrary, if we introduce the ring the other way around, during further manipulation there is a higher chance of further damaging the adjacent healthy zonules, and that's the reason why this should be avoided.